Okay.
There it is.
Okay, great. I I have a proposal already under review, but I want to work further on it and ask for further funding. I want to develop a protocol for virtual delivery of an evidence-based intervention for mental health of Afghan refugees and asylum seekers in Turkey. A little bit of background about the population that I'm working with. Currently, 1 in every 77 human being is forcibly displaced, so it's a crisis. When we are looking at the population, over 100 millions have been forced to displacement by the end of 2022. 1 in 200 is a refugee or asylum seeker, and the population will continue to grow. We have 27 ongoing wars and conflicts around the world. None of them are close to be resolved. So what we expect is that the population of forcibly displaced, specifically refugees and and asylum seeker, will continue to grow. The other aspect of the significance of the work that I'm seeking funding for is that 85% of refugees and asylum seekers live in global south, not global north. When they escape war and conflict affected area, they pass international borders to nearest safety. It's often global south. If such a protocol and the ability to provide virtual mental health interventions will kind of burden share between the global south and global north, because now Global South is taking the burden of providing services for refugees, majority of refugees and asylum seeker, while Global North resettle very small population of refugees and asylum seekers. For this population, escape from home is usually unplanned and abrupt, and after a traumatic experience, they often escape war-impacted areas. The journey to safety is challenging. It's not like that they can get a visa and use an airplane to pass a border. It's usually by foot, involves trafficking, injuries, and other traumatic events. Arrival to safety. Even after arrival to safety, they may face multiple challenges, including constant worrying about friends and family members who are left behind in unsafe situation. And they often live in exile for years and under temporary protection before finding a durable solution. Exile means that they pass an international border, arrive to safety, but they only receive temporary protection with limited rights, which is the case for Afghan refugees in Turkey, until they are resettled, go back home, or integrate in the community. Until then, they have very limited access to certain rights and resources. So mental health problems are common among this population, immigrants and refugees and asylum seekers, and there are multiple meta-analysis and systematic reviews supporting that evidence. The aim of my proposal is to adopt, refine, and pilot a protocol that it's a protocol for virtual delivery of an evidence-based intervention that has been piloted and tested among the population that I'm working with, that I want to work with. It is called Cognitive Behavior Therapy plus Problem Management. And I want to adapt it for virtual delivery among Dari-speaking Afghans in Turkey. So the strategy that I have for the study is forming a community advisory committee. I really wanted to have a community-based participatory approach in my study, but this proposal is for a pilot, a small scale study, short period of time. There's no way that I can pull that. So community advisory committee is the best alternative. At least I will have Afghans in that community, refugees and service providers who can advise us about the different steps of the project. We'll conduct a rapid need assessment through semi-structured interviews with 15 Afghans and 7 service providers in Turkey to get feedback about feasibility of delivering such an intervention virtually among the population. Then we'll design, kind of adopt CA-CBT, culturally adapted cognitive behavioral therapy plus problem solving. We will kind of adopt a protocol for virtual delivery, and then we will have a 12 group sessions using that will be delivered by 2 Afghan therapists for Afghan refugees in Turkey. 14, our sample size is 14, so we'll have a small sample size, and intervention will be delivered to a group setting. The outcome that we're going to measure is psychological distress, and we will use open trial, pre and post test. That's it. Again, it's a pilot study, very small scale. We will do process evaluation and then refine the protocol, which will include cognitive interviews, and we will look at any adverse events in the process, just exploring the feasibility of the study. And that's it. I'm an assistant professor at the Brown School. Also, I'm research director of the Initiative on Forced Migration on Brown School, Initiative on Social Work and Forced Migration, and I'm a new faculty. I just came to Brown very recently. My main question about the proposal is about the mHealth part. I'm not familiar with mHealth interventions. Virtual delivery was the best thing that I could think of. Yes, Afghans do have high level of access to cell phones. There are multiple studies supporting that refugees in general do have access to smartphones in different areas, specifically if they are living in urban settings, not camps. I have not thought about creating an app. I think that could be very complex, but the only thing that I could think of in delivering something from global north to global south was virtual delivery of it through video calls or maybe messages.
So that was a really great presentation, and I think you said that you have an application under review, but it sounded like you were maybe seeking competitive internal funding to sort of pilot this. So this is sort of like, launching your program into, bigger grant world. So you'll be looking for signals, right, in the data. I think in Turkey there are like 3 different cell phone providers or cell service providers, and I think they've got like a thing where you can buy a SIM card, a prepaid card, and then it only lasts for 120 days. So I guess that, would be if you wanted to do mobile health, and if you feel relatively confident that the majority of people would have access to a mobile device that's smart, and not just kind of analog, then that could be, a good option. But we usually would recommend that people that are running these studies actually budget money to purchase the devices for people. And so there are a few different ways that, you can do that, but this will also become important if you plan to apply for NIH funding. Then there's a few specific things that they'll want to know about how you're managing it remotely in an international study. But it does make sense that, like, if you wanted to do it all by telehealth, it seems like maybe you would still have to rely on like mobile devices, right? Because there's probably not much access to computers, I would imagine, in this population.
Yeah, exactly. And I have 3 collaborators in Turkey right now, and they said the same things, that I can purchase mobile plans with data that refugees can use for their sessions. We want to have video calls, and we want to use apps that refugees often use to have video calls with their family members across the world in different countries. And part of our need assessment would be what would be the best one to use. I don't know about how HIPAA compliance will come across if we find, for example, WhatsApp is the most used app versus a Skype or versus Zoom. And then asking them if they are like willing to use another app or another platform for their video calls. I think we will know through our need assessment about that.
Yeah, I have a few thoughts about that, but it looks like Hannah had some good questions. Hannah, do you want to unmute and talk, or I can ask for you if you prefer?
Thanks, Mitra, for the presentation. I guess, so I work on some studies that work with people with opioid use disorder who are usually lower income, who don't always have constant cell phone access or just have, maybe their lives are very busy. I was wondering if there's any way to consolidate the sessions or even have them be individual. I guess I've even been reading in the literature too, is that a lot of people are hesitant to have some of these groups over the phone. And I've heard again, that's just kind of what the literature is showing now in the COVID and post-COVID times. So I was wondering about consolidating some of the content into fewer sessions or even having the sessions be individual, or there's any way to have some of the content you want to deliver to be asynchronous. So right now with one of our group's interventions, they have access to an app for about 30 days. And then they also have some e-coaching. So maybe there's some ways you could have access to content and then maybe access to someone, through text or through WhatsApp if they're needing extra support. But I'm just thinking about having to organize 12 different groups with different folks might be a task, especially if people are, they're dealing with different challenges with migration. But really exciting proposal.
Yeah, so the reason that we're doing 12 group sessions is that 12 group session of that protocol in person showed promising outcomes among Dari-speaking Afghans in Germany. So we have that evidence. We said, okay, we'll adopt it a little bit, deliver it virtually, and we'll see what happened. But I would love the idea of asynchronous, some of the components being delivered asynchronous, because I'm sure that getting people together for 12 sessions would not be that easy. So yeah, I will think more about it, that how much of an adaptation we want to push for in this proposal.
Yeah, I had the same, thanks for the nice presentation, Mitra. I had the same reaction, just that I imagine just even this group and challenges that they may be experiencing in their lives, just even the logistics of getting groups together. I mean, we know in general, group therapy is really hard to pull off oftentimes, even in sort of the most resourced populations. So I would a little bit worry about feasibility. So you could consider in this early pilot project, maybe even gathering more information from the population on how they'd want this intervention delivered. Per Hannah's point, is it, kind of like brief individual sessions? Is it a digital platform that you might develop, et cetera? And just one other comment I'll raise maybe at the same time is, if the next step is to maybe, go to NIH and seek further funding, I think it's always great to think about, how will this work make an impact? And I think reviewers like to see that as well. So I guess I'm starting to think about, or maybe you already have these connections, are there certain nonprofit organizations that serve this population that you could see actually being the place where this intervention is deployed? So maybe starting to build some of those relationships now, or, again, seeing what that organization would be interested in helping to support. Maybe they're most excited about building an app or a digital platform or something. So I think, just kind of thinking strategically now, maybe about what relationships you need to develop to find like a platform that this can kind of live on, so that, you're scored really well on kind of like that significance and impact piece by your reviewers. Again, there's a clear delivery mechanism for what you're ultimately, wanting to develop and test here.
Yeah, I think I have a long way for NIH grant, so that's not like even in my plans for this year, maybe next year. It's some preliminary data. It's very exploratory, but the aim is to burden share. I don't like, yes, we want to train some therapists in the global south to be able to deliver same intervention, but my goal, what I am arguing, is that global north should have centers that provide mental health interventions to refugees in the global south if they are not resettling large populations, if they are that selective, so they can provide services at least virtually or through mHealth.
I was just gonna say the same thing that I think is happening in the chat, but kind of along the lines of what Hannah and Ellen were saying, I think another big thing for future federal grant applications, it's never too early to start, grantsmen or womenship, to sort of think about your strategy. But you're right, creating a digital tool that can do all of these things would be very expensive if you had to do it de novo. And so identifying digital platforms that maybe are already deploying something similar or that have the capability of linking you in a HIPAA compliant way via video chat, I think that would probably be the most important thing. And then, just a platform to save content that's asynchronous and that people can do as self-guided. Part of it I think that would be what would make the most sense, because I know lots of people on this call have, done app development in an academic setting, which is relatively resource constrained compared to industry in a lot of respects. So that would be the other way to think about how to get it developed and working, would be to identify, I think Ellen you were probably referring to this too, but like identify a new or early kind of startup phase nonprofit that's interested in this space and co-develop it with them.
Yep, exactly. Like finding other stakeholders, even across sectors, or they're both nonprofit organizations and anybody in industry kind of interested in this work. And like you said, even though your NIH grant is maybe a year or more down the line, I know these conversations can take sort of an eternity to have. So as Ginger said, I don't think it's ever too early because everything takes such a long time. So just maybe spending some time now exploring to see what other partners, again, may make sense, because it totally, I agree, you don't want to really develop a platform all on your own, especially in this scenario, I don't think. So finding something you can leverage, and, again, like what might be out there might also then inform the kind of questions you ask your participants, right? Because you're going to be a little bit potentially, what maybe you think you can deliver, is not maybe fully under your control. Like there's already maybe some things in place, like Hannah's saying, like, does WHO or the UN, do they have any like digital mental health resources that you can bridge off of or something?
Yeah.
But I know I saw a hand.
Yeah, I think Allison, I just messaged you, Allison. I saw your hand up. You want to ask your question?
Hi, I'm Allison Matthews. I'm in the Bioethics Research Center on the Med Campus, and I work with some folks in the Institute for Informatics that are building apps, mental health apps, and I could give you the names of some folks that might be great to talk to or who to connect you with. And absolutely what their experience has been is you have to partner and build from things that already exist. So just feel free to email me and I can give you some names of folks that might be worth talking to for 20, 30 minutes even.
That might be a good thing for us to, put our advertiser link to on the MHRC website. It sounds like that would be a good thing for others too. So if you're willing to share, that would be great.
Yep.
Yeah, these are all great points. And I will also reach out to you, Melissa. I saw the text in the chat. UNHCR does not have a currently virtual app or anything related to mental health delivery. WHO is working on one. I have contacted them They have several ongoing projects, but I think they are also figuring out what they want to do. And based on the connections that I have, like when they are ready, they would be willing to let me pilot. But it seems that they are not ready as well. And I think WHO will be an amazing partner if I can make the connections that I need to make to be able to pilot something that they are developing. Yeah, and I used to work with UNHCR, so I'm more familiar with what they have and what they don't have. So I think WHO could be an amazing partner. Yes. Thank you.
And do you have a deadline for your funding application?
I'm waiting for this one that it's under review to see if I want to expand or submit a similar one. I should know within a week or two about the result of this one. It's a very small grant, $25,000. And then the alternative that I'm thinking about is an internal grant through Brown, through my school, that it's $50,000. And I will go from there.
Yeah. Okay. Well, you just keep us posted, and if there's anything we can do to help as you're revising or planning another submission. But this has been a great discussion, and I think we're done a little bit early unless anybody's got other questions to ask Mitra or comments.
Yeah, I have a quick question. So if I need a letter of support or further help when I'm revising the proposal, I can reach out to your team directly, right?
Yep. Yeah, we have some kind of boilerplate stuff for you to put in your facilities and resources and budget justification. And then we would always write a letter. Anyone who's an MHRC attendee or on our listserv, yes. So all you have to do is just let us know when you need it, and we can put it together for you.
Thank you.
Okay. Well, Kelly, are you ready? Okay.
Yeah, let me get my screen sharing going. Oh, perfect. Can you all see that?
Yep.
Okay, excellent. So I'm Kelly Harris. I'm Assistant Professor of Occupational Therapy and Surgery here on the med school campus. And I want to talk about my proposal for a technology-enabled service to facilitate care coordination for youth with asthma. So in terms of background, asthma is the most prevalent chronic condition impacting youth. It's a difficult to manage chronic condition requiring ongoing medical support, limits individuals' participation in daily activities, opportunity, and life expectancy. And it affects more than 6 million youth under the age of 18 years old. Asthma impacts academic outcomes directly through cognitive deficits, impaired concentration and memory, reduced attention and motivation and stress, and indirectly through school absence. We know that youth with asthma are the largest population of youth with chronic conditions in K-12 schools. I feel like that's something that I know mental health concerns have really increased. So it's one of the top, I guess I'd say. And prevalence rates remain highest for youth between 5 and 19, with an average prevalence of around 8.6% and up to 11% for adolescents in the 15 to 19 year range. And for youth, Missouri actually falls in the highest quintile in the country, with average prevalence rates of around 10% and a range of 9 to 12.5%. And we know that asthma places an undue burden on racial and ethnic minority youth. So here in St. Louis, where my school partners and my work is primarily located, prevalence really aligns with racial and economic segregation in the region and disproportionately impacts Black youth and youth living in households with lower household incomes. So all of that said, asthma is really a priority for schools and pediatric health providers, and is really an ideal population to think about developing a service model as a solution for chronic disease care coordination and management. So we conducted some preliminary work. We've been working with a couple of, with a school district partner and then some community health partners that already partner with that district for about 2.5 years. And we were able to kind of build an asthma collaborative team where we were able to kind of think about priorities from that perspective and then develop a formative assessment that we conducted throughout the district to identify, kind of key barriers and key priorities. In that preliminary work, really found that care coordination was a primary concern or priority for district stakeholders. So that includes school personnel as well as families and school health providers. And this is really, how we're kind of defining the problem space here. The family carries a primary responsibility for care coordination between settings. So youth will get their medical services in a, healthcare institution like children's. And then they also might receive health services in school via school nurses or school-based health centers. And the family kind of carries that burden of communicating between these systems. And it's often ineffective for a variety of reasons. So we know that, in school settings, students might receive services from a school nurse, like I said, a school-based health center, or we have a mobile asthma van that goes from children's to several schools in our region. My partner district is one of them. And those three entities are bound by their own kind of privacy regulations that prohibit them from communicating about the students that they care for. So even within a school setting, a school nurse can send a student to the school-based health center and not be able to receive follow-up based on kind of the those respective privacy regulations. So we know that our healthcare institutions maintain records through Epic and share information with families through MyChart, but can't communicate directly with school providers either. The school shares information with families through their school information system or their school record system, but not with the healthcare institution. And often, like I said, not with the school-based health center nurse practitioners or mobile asthma van providers that have access to that medical record. And so kind of given those challenges without family or parental input, really only that the primary care provider can only communicate with that family as well, or with the mobile asthma van provider. So it creates, a communication and information sharing or care coordination challenge. So the aims of my proposal are ultimately to create a care coordination dashboard. So to develop a technology-enabled service or service model to facilitate care coordination and communication between medical and school settings for youth with asthma. And so ultimately, we want to build an integrated infrastructure to combine that information and essentially like a central location that creates this integrated dashboard with a goal of improving student and school level outcomes. So the care coordination dashboard would bring together existing information from different sources and then collect any additional needed information that's not captured in those existing sources. So, this is essentially my aim one, with a kind of sub aim 1A being to pull information from a AHR to a central location, and then aim 1B being pulling that school level information, like attendance, for example, in as well. And the second and third aims would be aim 2 would be to identify or develop implementation strategies to support the implementation of this dashboard, and then some usability testing for aim 3. And this would then prepare me to do a full pilot and a subsequent R01 proposal. So ultimately, this is kind of what I would hope to create. A model that looks more like this, with this kind of central care coordination dashboard facilitating the information sharing between the two systems, healthcare and school systems, and limiting the burden on families. And so there are logistical challenges in doing this and thinking about, kind of legal and logistical implications of different health systems. So I would want to, in this, develop something that works with just one healthcare institution. So focusing on our healthcare providers and engaging 1 to 3 providers actually in the research team to kind of build this and then and do some usability testing, engaging 2 nurse practitioners that work with Healthy Kids Express, the mobile asthma van that actually serves the school, and then 1 to 3 school providers to kind of limit or eliminate some of those initial logistical and legal challenges to a project of this nature. So I'd want to engage them in the design and usability testing. And so the plan, there's supposed to be animation on here, and you can't see it. So sorry about that. I want to use the accelerated creation to sustainment model. So if you look at just the top, this is kind of the model, and the orange box at the top is we would focus this work on this first create phase, where we'd use human-centered design and human-computer interaction to really go through an iterative design and evaluative process to design that infrastructure. And so then the bottom row just kind of applies it more to this type of project. And these images are from work by Moore and colleagues that built a similar kind of service model looking at mental health in schools. So ultimately, the goal would be to have a functional and usable product with protocols and an implementation plan at the end of the proposal, and then future proposals would look at hybrid trials for optimization and sustainment. And I think that's all. Thank you.
Does anybody have any questions? If not, I can start. That was a great presentation. So you might have already said this, Kelly, and I might have missed it, but I guess kind of along the same lines as what we talked about with Mitra, it's always better to, adapt something than it is to just create it yourself. And I'm kind of curious about what your experience has been in that space of creating, and have you identified a tool that you're planning to use? And then the other thing was, I'm sure you've already probably thought about this, but if not, WUPark would be a great stakeholder to engage, which is, that's the pediatric research, the practice-based pediatric research network for WashU.
Yeah, so I have thought about that to the second point. So there isn't, that I have found, there isn't an existing model that's easily adaptable. So we did a review of kind of asthma mHealth tools, and most of them are focusing in different areas. Asthma control was the primary focus for a lot of them, and like self-management. And that gets at some of this, but the other thing we found in that review is that success was really limited in part because of the types of tools. So it's mostly like smartphone apps for families and students. And they don't really want, this would be more for like school nurses to use to coordinate care across settings, and less for, the idea is not to create an additional burden for families or students. So I've looked at that. The only other care coordination app that I have seen is like the Check, I guess, app or system that was used in Chicago. And one of the challenges there, I think, is it was kind of a be everything for everybody resource, and that's not what I want to do either. So I guess the short answer to your question is I don't know. I don't think I've found anything like that, which is why I think that I'm kind of still feeling like development and using what exists, though. I think getting a clear understanding of what the school already has and making it as, adapting or adjusting if we can, because we want something that integrates with an existing system. We also don't want to build something separate from the school system that is an additional burden on the school staff. That answer? Okay.
Yep. Yeah. And I think that's, what's cool about your proposal is that you're proposing something that doesn't exist. And so, yes, it needs to be built, but I think, maybe the group that's listening could offer suggestions if they've done anything like this. I know what we've done is, instead of creating an app, creating a web app, which is basically a website that looks like an app. And then you can do, your own website development and try things out. But that, kind of requires that people have access to Wi-Fi. And so this might be a population that doesn't always have reliable access. So I think the, kind of groundwork of finding out what everybody would need, if you wanted to eventually bring in families, which would be really cool and also very novel. But I think, for the provider set to start with, it seems like a website might be a good way to start. Ellen, what do you think?
Got a couple.
Oh, sorry. Go ahead.
I have a couple of thoughts too. I don't know. So my name is Mike Durkin. I'm one of the ID faculty. I do a lot of stuff related to non-asthma topics. So I'm not going to be very knowledgeable about that. But I will say that having like used Epic a lot and what other people are talking about, sometimes it's easiest to use, try to adapt or use stuff within the existing lanes and then try to see how to make things better. There's EHR contains a lot of information. So figuring out what you need to share is going to be important. And the key things that are somewhat limited because you don't want to give someone like a 20-page document when you have a kid that's having an asthma exacerbation in the school, because they're not going to be able to look at all of it and find the relevant information. I would think that you could do something as simple as like an asthma action plan, you know, for the nurse to be able to follow, that would say like if their peak flow meter is below this, then they can use an inhaler. If they're below that, then, you know, you need to call their parents and have them get a nebulizer or something. And if they're below some critical threshold, go to the emergency department. And I think most physicians will, and like healthcare providers will, give patients asthma action plans, but that information is probably not relayed as well. We can send stuff to other healthcare providers in Epic via at the end of the note. So I'd be curious, and I mean, some of this could be like sharing, like how comfortable they would be, but if the parents are okay with it, viewing the school nurse as a healthcare provider, and then sending the encounter summary to the school nurse, and having the school use their existing infrastructure to do it, to have that on file or whatever they've got with their kid, would be, I think, an easy first step that I could see as being feasible. And the school nurse could easily get those faxes or reports or however it's sent to them, and then organize it. And it would be, I think, if you were to write a grant like that, I think the NIH reviewers would say, yeah, you know, that's already using existing Epic tools. And like, I think it's feasible to do that, and sending the asthma action plan to the nurse would be something that could be done. It'd be really cool to have this like integrated, like housed network of EHR and school data, but it's hard. It would be very hard to do, and it would cost a lot of money. So like it would be probably several grants down the road, I would imagine. But
yeah,
for
it's always good to say that up front, that you're thinking about it, because reviewers will want to know that you thought of it.
Yeah, exactly. I would write, this is my long-term plan, and have that image, that figure in there, because people will love it and say that looks awesome. But say I can't get to that until I do these other things first, and this would be a first step. That's just what I would think. I don't know what other people would think about it, but you wouldn't have HIPAA problems or people hacking stuff. If there were problems with it, would be on Epic instead, you know, or on the school, rather than like problems with your database.
Those are such helpful comments. Thank you for that.
Yeah. And I think really helpful, Michael. That's exactly like kind of where I was going to go. I guess I was just going to express some concern about, you know, how are you going to get these, you know, physicians and school people to access like yet another kind of platform or resource, even if, again, the goal is very noble. Like, we all want care coordination, but we also know these providers are very busy. You know, and I keep hearing in relation to things with like physician workflows, like if it's not in Epic, you know, it's not going to happen. And so I really like the suggestion of maybe like what's possible within Epic or outside of asthma, you know, what similar kind of projects have been done to start to use what's available there for care coordination, like in the long term. And again, I'm not an Epic guru. I don't really do research in this space, but I'm just thinking like it'd be really neat if there were like add-ons or, you know, plugins or something where it's like, you know, there's something within Epic that, you know, the physicians already have easy access to, but then there's these, again, like plug-in platform type of things that maybe other systems could integrate into. I don't know if I'm making complete sense, but again, you're kind of building on what at least the physicians are already using on a day-to-day basis. So I really like Michael's suggestions.
That's really helpful. I mean, that was the idea, is to not add another step for providers, because I recognize that, right? It's like unlikely to happen. So to something that automatically pulls information that they already are entering was what I was thinking. So
you know, I put this in the chat, but you know, what we're all talking about is, if I have the same understanding as everybody else, another aspect of this could be, what are the main conditions that school healthcare providers need to treat in the school setting or often end up managing? And then could you start with a framework that could be loosely applied to all of them, and then use asthma as like your index way of building and developing, but sort of with the end goal in mind that using the existing electronic health record is what you kind of optimally want to do, right? You want to create something that eventually can go into that, but it would be great if it's like a template kind of. So like the content creation and the back and forth and sharing of information.
So, thank you. I think so a grantsmanship question, I guess, is that is a long-term goal. And thinking about asthma as like the ideal condition to do that because it is a priority for schools, because it is so common, was framing. And I guess I've been unsure about how much to say that on the front end because I guess because it's
well, I mean, it's kind of, I don't know. I would think about it like, your first paragraph of your AIMS page is really all about why this is needed. And you get to maybe kind of expand on this is, asthma is really important, but this is a chronic care model that could be applied to many other conditions. And ultimately the goal is to create something that is usable across these common conditions, ultimately, right? But that it starts with asthma, and that's how I would do it.
And this is a K-23, right? So I guess too, that's the important consideration is like, I mean, your aims are important, but that's just like part of it, like really you and your training plan kind of get more weight even in those review criteria. So maybe, you have a whole training goal around sort of becoming like the expert in like care coordination of, school-based sort of like chronic illnesses. And then you kind of just describe in that training plan that, this asthma project is sort of like the test case, and it'll, again, like kind of get you started in this work. But again, it's ultimately maybe a model that, you and others, could apply widely. So I think that would be a pretty compelling sell. And again, then you're just the research project anyway in a K is kind of just meant to be like a demonstration of, using your skills that you're developing as part of the training plan. So I don't think anybody would expect that your research project should cover like all the conditions possible, or anything like that.
Yeah, those are good thoughts. Oh, Michael sent a cool link for anybody who's not looking in the chat. Check it out. So do you think, are there other thoughts or, kind of comments or ideas or questions for Kelly, or vice versa, Kelly? Is there anything we haven't covered that you wanted to discuss?
I think you guys have answered my primary question. And that was really kind of around how to break it down. And so I feel like a lot of the comments have already kind of gotten to that. So that's helpful.
Yeah. I mean, I think maybe the thing we could talk about a little bit, because we have started to think more about how we're going to help people get, their start, right? So working with trainees and junior faculty to start their research programs. So this is a place where MHRC could probably be helpful, because we could, provide some career development text for you along these lines. And another kind of one of the things that we want to also try and do in the coming year is develop some guidance for investigators on what is industry and how in the tech space, and how do you interact with them, and what are the different things that you need to think about. And so this could be one example of, an educational content that you can, we could populate your career development plan with some text to describe.
That would be great. One other question is actually about a comment in the chat about the Aspen platform. Hannah, do you know folks?
Yeah. Sure. So we partner with Jefferson County Health Department. And I mean, this has taken a little bit of time for them to roll out, but it's a platform that parents and students can opt in on that in that county. And it's basically kind of a centralized place where there's resources, but also they can put in, like the school counselors can put in school notes about the mental health of the student. And there's also just some, they can fill out, you know, like, again, this is more like mental health, like the PHQ, the GAD-7 and the Columbia screener for, for suicide risk. And so it's just kind of a centralized space, and it's, it's HIPAA protected. But it's also, I think, a space where if a kiddo like had concern about a peer, they could also, alert school staff. So that was just something else that was a little similar to your thought, but just kind of like the centralized platform to better have coordination for student mental health. But so that's Jefferson County Health Department. And I know they also have, they're trying to launch a similar platform for first responders too. So I know Jesse Gold has worked with them as well. But
that's a good call. I remember them now. I'm like, why does that sound familiar? But this sounds like a great resource to check out.
Yeah, I know, but I know it's also.
How did you find out about them?
Oh, so I mean, we just have contacts in just Jefferson County. So we work with their treatment court and some other, for-profit clinics through one of our other apps. And so we were trying to, we're in the process of rolling out an adaptation for teens. And so we were trying to think if we wanted to pilot with them through this platform. So we might do that at some point. So.
I mean, that's also helpful to know that you're kind of thinking about your project in a similar way, that you want to use an existing platform and that you already have actually used this platform that way, it sounds like.
Yeah. Yes. And they're really, really nice. And I know that they're more than welcome to show you the platform, but also talk about what was the easy part, what was not the easy part. And I know that a lot of the legal piece was tricky since, just with working with minors. So
yeah, we'll have to get maybe you could send us the website or whatever the resources that you use to connect with them, and we can make sure it's on our website as a resource too. I think both of these projects just sound really outstanding and exciting. And I think too that this group can probably, offer even more support and helping you as you're finalizing your applications. So don't be strangers. Let us know what you need, and I'll send a follow-up with some examples of the text that you can incorporate into your grants.
That would be great. Thank you so much to everyone. I appreciate the feedback.
I'd also like to say, this is from personal experience because I've made this mistake a lot. You can search an NIH reporter for stuff. So if there's anything that like you think is a good idea, you can look to see if somebody else has already thought of it. They have, then you can figure out what they're doing and then try to say like this other group's doing it and I want to make it better. Or you can say, oh, this other group's so far ahead of me, there's no chance it's going to get funded. I got to think of something else.
Because that's what reviewers do. We look.
Yeah. And it's great if you're applying for case or other things, you can see potentially who they are and see like, hey, maybe I could reach out to this person. They can serve as a mentor. So if anyone else were to look in reporter, they can say, hey, wow, this person's like working with someone that's already got grant funding related to that too. So I didn't start searching reporter until like way too late. So it's super useful. If you just Google NIH reporter, you can use kind of any search terms and look up stuff. So
yeah, that's great advice. Okay. Anybody else going once, going twice? Okay, so I think we're probably done a little early for today, but thank you all for joining and for just this really great discussion. And thank you, Mitra and Kelly, for your ideas and preparing and spending time telling us about them, because they both sound really fantastic. And so we'll send a follow-up email to share some of this information we've talked about. And then we'll also stay tuned because we'll be having another seminar before you know it. And we look forward to seeing everybody then. So, all right.
Thank
Bye,
you
everybody.
both. Thank you all. Bye.
Bye.